Hi, this is Brian Kim. I'm going to share with you the Injector-Assisted Haptic Fixation technique, which is a modification I developed back in 2017. And it is an easy way to fixate the leading haptic into the needle on the left side with the Yamane technique. And so I showed a previous video using the CT Lucia 602 lens. This lens has very strong polyvinylidene fluoride haptics, which makes it a much easier lens to thread the haptic into the needle. However, I'm going to show you in this case, this is an MA60AC lens that I'm using on a SimulEye's eye, and I'll be able to demonstrate to you using a 27 gauge half-inch needle, threading the MA60AC haptics into the needle and be able to do this modified Yamane technique. For this technique, you want to bend the left side needle about 9 millimeters and at a 70-degree angle, and you want to make sure the bevel faces towards the approach of the haptic. So it's very important when you're holding the needle up and down that the bevel needs to face towards the haptic. On the right side, the bevel faces towards the haptic as well, and is facing towards you. Both needles are facing towards you with the injector-assisted haptic fixation technique. The left side needle is placed 2.5 millimeters posterior to the limbus and tunneled 2 millimeters into the sclera parallel to the limbus. I'm holding the needle with my left hand, and in the right hand, I'm holding the injector. The bevel faces towards the approach of the haptic. The technician advances the IOL, and the surgeon directs the haptic to slide into the needle. You want to make sure that the haptic is going to be able to dock on the bevel of the needle. The technician should advance the haptic only a small amount and only when the surgeon says to. And so this is very important. Because these haptics are more brittle, you need to be able to coordinate pushing that haptic into the needle. This requires clear communication between you and the surgical technician. These PMMA haptics do not slide very easily into the 27 gauge needle, unlike the CT Lucia 602 lens, which slides very smoothly into the 30 gauge half-inch thin-walled needle. Again, these PMMA haptics do not tend to slide easily into the needle. So you have to use careful coordination and make sure you angle the haptic in the needle in such a way that the haptic slides into the needle. Once the lens is delivered, the trailing haptic is swept to the right. I'm using the needle here to measure 180 degrees away, and then I'm placing the needle 2.5 millimeters posterior to the limbus, tunneling it 2 millimeters before entering the vitreous space. You can see that the trailing haptic is left out of the eye. I don't have the U-shaped configuration here. I'm able to grasp the haptic through the main incision, and remember the bevel is facing towards a curve. This is the easiest way to dock the haptic on the bevel of the needle. The haptic is straightened and then carefully advanced into the needle. Because these PMMA haptics are so brittle, it's so important not to force the haptic into the needle. You want to make sure it's nice and straight on the same axis as the needle. You want to push it little by little without traumatizing the haptic. Now both haptics are fixated in the needle. You're able to withdraw each needle in the direction in which it was placed through the sclera, and you can see that as the needle is pulled out, the haptics are externalized. Now on a real patient, I prefer to pull one needle out, cauterize one haptic, and then pull the other needle out and cauterize the other haptic, because in my experience, there is a small chance as you pull out both needles that one of the haptics can slide back into the eye. So this is the injector-assisted haptic fixation technique for the Yamane technique, which I developed back in 2017. And this technique allows you to fixate the leading haptic very easily and directly using the injector to slide the haptic into the left side needle. You don't have to worry about using microforceps to grasp the haptic and tunnel it into the needle. You might accidentally bend the haptic. You might accidentally break the haptic. In this way, this is really a no-touch technique, guiding that leading haptic into the left side needle. Normally, I like to capture the trailing haptic within the incision in a U-shaped configuration. It didn't quite capture it in this SimulEye's eye. You want to leave the trailing haptic outside and then grasp the haptic in such a way that it gives you a little bit of room. You'll be able to thread the trailing haptic into the right side needle, you want the needle bent in such a way that the bevel faces the approach of the haptic. You're able to grasp the haptic with forceps, dock it on the bevel of the needle, and then very gently inch it in little by little, being able to thread that haptic into the needle. Because it's a 27 gauge needle, it's a pretty tight fit for this PMMA haptic. You can externalize both needles and then cauterize the tips. If you prefer to do the original Yamane technique, then I believe injector-assisted haptic fixation is a nice addition to that technique. However, honestly, I prefer the trailing haptic first modification, which externalizes the leading haptic through a contralateral incision. This is a much easier way and more elegant way, in my opinion, to do the Yamane technique. So I hope these tips were helpful to you, and I thank you for your attention.